slides. Can you see my slides?
Sure. Yes.
So I can go ahead. So I'll try to
Yes.
now to spend the next few minutes in trying to put a little bit of the pieces together, and focusing clearly on how clinical manage these complex patients, have to deal with, pseudocarcinoma carcinoma on one side, but also cirrhosis on the other one, because we have a number of tools, and it's important to have clear ideas how to manage them. Now, after, I would say, 35 years of huge exposure, clinical exposure to hepatocellular carcinoma and in deep, study, I would like to try to make a super synthesis about the management of hepatocellular carcinoma in 3 big pillars. And I hope you, Giuliano, in particular, you will agree with me. On one side, there is therapeutic hierarchy. I will have time to talk a little bit on that. On the other side, of course, there will be transplant benefit, which is, and therapeutic benefit, generally speaking, which is a major conceptual change in our way to think to the results for these patients. And the third big pillar is the understanding of the biology of the tumor, because I couldn't disagree more with Paolo De Simone saying that the burden of the disease is a major determinant how we choose our therapeutic option for this patient. Is a big mistake, because this is a surrogate of biology, which is a primitive surrogate, is an absolutely imprecise and gross surrogate of biology. We should go a little bit more into detail on biology. I won't have time to speak about that. We have biomarkers, we have radiomics that is coming more and more in the future. We have response to therapy, test of time. We have a lot of, new insight in mirroring biology of the tumor. So I won't talk about biology anymore. I will focus on therapeutic hierarchy and transplant benefit. What is the concept therapeutic hierarchy? I think that I don't need to recall. I hope that many of you had the possibility to see and read this Lancet Oncology paper we have been publishing in 2023 with a group of Italian hepatology, but not only Italians, you will see in a minute, stating clearly that should we promote a change, go from the classic prognostic stratification of the patient and allocation of the therapy, which is an old-fashioned approach, which was linked, at least, mentally associating a stage to a therapy, intermediate stage chemoembolization. Then, of course, you can do a stage migration, but the association is so strong that in non-expert centers, intermediate patients are treated with PACE, no matter how, but this is the reality. So what we are proposing is to move on from that old, paradigma, the BCLC paradigma, and state, okay, you clearly have to stratify patient according to expected outcome, but then the treatment delivery should be a totally independent mental process, a conceptual process that is supposed to be totally independent from the stage of the tumor. Why? Because the therapy is so relevant in terms of prognosis for these patients, has a so relevant impact on the prognosis that is an independent prognostic factor. So it's supposed to be considered independent in the decision-making process. Let me go into the details. This again is the Lancet Oncology. You can see here how independently, this is a multivariate analysis. So in an independent way, the therapy, different therapy like liver transplantation, resection, ablation, transarterial embolotherapies, sorafenib, and the other systemic therapies are associated with the nasal risk as far as survival is concerned, which is much different. Liver transplantation is beneficial with the nasal risk of 0.18 versus resection is 0.35, and then an increasing risk, ablation 0.50, embolotherapy 0.72 and 1.7 for systemic therapy. There are many of these evidences in which multivariate analysis is showing that liver transplantation is better than resection and better than ablation and transarterial and so on and so forth, independently at the multivariate analysis. And again, looking at evidences out there, if you go for every single stage, for example, early hepatocellular carcinoma or intermediate hepatocellular carcinoma, you clearly see that if you deliver a better, a higher, hierarchically higher therapy like resection in an intermediate phase, in intermediate stage, then you achieve a better survival than TACE. And if you deliver in these patients with an accurate indication, liver transplantation, you achieve better survival in an independent way. So therapy is independent from stage. That's the reason why we elaborated this. I don't know, Giuliano, if you had the chance to see this scheme. That is what we propose in a practical way for the management and the therapeutic allocation of each particular hepatocellular carcinoma patient. It's very simple. It states that you need to exclude a hierarchically very strong therapy independently from stage in each particular patient. You see an intermediate patient in our outpatient clinic. First of all, you should exclude liver transplant. Why? Because that is going to be associated with better survival. And how do you do this process? In a multidisciplinary setting, high volume, better, and high expertise. And it's easy because, first of all, you consider general condition. If the patient is a 90 years old patient with very severe comorbidity, of course, you exclude transplantation and you go to the next therapy available, hierarchically speaking. If the patient has a performance status greater than 2, or if it has metastasis, you exclude transplantation. It's very easy. What we do in a clinical setting, no? But also, if you have an adverse biology, you have to exclude that patient from transplantation. Not according to criteria, because criteria are old-fashioned. Might be according to, again, alpha-fetoprotein, PIVCA, stable disease, progressing disease according to pressure of therapy, response to downstaging, you know, the things that we know that reflect really biology of the tumor. And then you have to consider also your waiting list, maybe because you have a long waiting list, and you should consider that as a infeasible or low feasibility of that particular choice. But at least you consider the best therapeutic option for that particular patient. If this is not feasible, then you have to exclude minimally invasive liver resection, which is associated to a better survival to liver resection open. This is not banal, Julian, because, for example, many centers that do not have expertise deliver open resection, which is not the case, and they reduce the chances of survival of that patients and should refer those patients to high specialty and high minimally invasive patients, so in many centers and so on. And this is true for percutaneous ablation if you consider, for example, that the location of the nodule is not suitable for a resection. This is not taken into consideration in any guideline, but for a surgeon is the most relevant piece of consideration when you consider resection. If you have a central 2-centimeter nodules and you have to do an extended right resection, maybe this is not the case, and you should, you know, pass over the patient to your radiologist for a percutaneous ablation, because it's much easier and it's much less, you know, much more parenchyma sparing. So consider adverse biology, but also location. And, you know, if percutaneous ablation is not doable because of the position or because the patient is fat, you cannot see the nodule, you have mandatorily to consider the video laparoscopic ablation approach, because this approach is associated to a better survival than chemoembolization, independently from any particular, for any particular location of the tumor. So consider video laparoscopic ablation and then forward to embolotherapies and to systemic therapies. So there are a multi-parametric analysis in a multidisciplinary expert center. So how about BCLC? What should we do with BCLC? Should we throw the BCLC away? I mean, after all these years of usage or partial usage of BCLC? We don't think so. We think that there is a good integration between our philosophy, which is very practical, very evidence-based, very clinically oriented way to proceed, and the BCLC. You should stratify the patient according to the BCLC in order to see which is the state, maybe including the patient in a study according to the stage of the disease. But in the end, and this has been very nicely published again by us in Journal of Pathology after an invited review this year, after staging as a general guidance and benchmark of what you're doing, then your decision is supposed to be totally independent from that particular staging, and you go ahead with the best therapy that you can deliver. And then this process can be applied also to the second recurrence or progression of the tumor or conversion of the tumor. And this is our philosophy. And I think according to the citation and the visualization of this paper, which are massive, I think is very much appreciated in the international community. But so in this philosophy, liver transplantation is the best ever. Is that true? Is it really true that this is a best ever therapy? Yes. The response is yes. In a world where you have infinitive availability of organs, you achieve a better survival in all studies and massive evidence out there that liver transplantation is associated with increase of overall survival and a massive increase in disease-free survival. But it's pretty clear. You do a very good resection, oncologically speaking, with very relevant hazard ratio and advantages. And even mortality, Julian, you were saying, which is the postoperative mortality, is higher in liver resection, overall considering, than in liver transplantation. So there is an advantage. And indeed, when this Italian guy went into the details of the reason of death, they show how the cumulative incidence of tumor-related death, which is very interesting, you know, in a competitive analysis, which is the tumor-related death after transplantation or resection. Well, liver transplantation is associated with a very low profile of tumor-related death. So even in a very high risk of intermediate, low intermediate risk patients. So clearly, because you treat the tumor much more than the liver resection, which is in a way kind of loco-regional, very limited kind of approach. So transplantation best ever, and you should consider always transplantation first in this setting. But we don't have transplant and organ available for everybody, even though we have much more transplant available now. So you should select which are the patients to be transplanted according to the transplant benefit or the therapeutic benefit concept, which is your alternative to liver transplantation. Is that a chemoembolization or a systemic therapy? The benefit is huge because, you know, the expected survival after 5 years is very low. So you achieve a lot of survival with an organ. But if you can resect that patient, your benefit is very small. So in our hierarchy of benefit, considering liver transplantation, you should put at the first place the BCLC-D, the opposite around of the BCLC suggestion, you know. So advanced liver disease, responding to therapy, or without any other choice should be considered for transplantation first. Then, of course, you have to filter the patient according to biology and selection for criteria for transplantation, but these are first. Then the BCLC-B are the second in place after successful downstaging, or even after conversion therapy. You do immunotherapy, you have a good response. The benefit for that particular patient is massive. And then what should we do for the BCLC-A, the classic indication for Milan criteria, as Giuliano was saying? Milan criteria indication are the worst candidate for transplantation because the benefit is very low, because this patient can be resected. They can be ablated very easily. So you should select the only patient for transplantation with a high risk of non-transplantable recurrence. So let's go a little bit into this concept of non-transplantable recurrence. So we now have enough evidences to say that when you have a high alpha-fetoprotein, more than one nodule, a cirrhosis, which is a borderline cirrhosis, your risk of having a non-transplantable recurrence in the next years is about 40% of the cases. So that is a patient that you should suppose and present. Even so, even though the patient is resectable, you remember Duilio was saying we resect all the patient. Yes, okay, but if the patient has multinodular disease, a little bit of high alpha fetoprotein, and a cirrhosis which is not convincing you, liver transplantation is supposed to be considered first. Or an ALBI score, or a total burden score high, then the 40% of these patients will recur. Now we have better prognosticators. You have vascular invasion, R1 after resection. So even after resection, you can detect those patients that are at high risk of early recurrence. So it's very good to address to transplantation those group of patients, and this is something that we have. So let me play around a little bit with a clinical case, You have a patient within conventional criteria for liver transplantation, let's say Padova criteria. You have a good donor resource available, like today in Italy, we have for 24, per million of donors. And you have a patient with low intermediate benefit for transplantation is a patient which is resectable, or a patient which is not resectable because it's the compensated cirrhosis. So in this patient, you go immediately for transplantation. A very easy choice, very easy choice. But if you have a resectable patient, you should consider the non-transplantable recurrence predictors, and the patient has high probability of recur. You should go immediately for transplantation, not to resect that patient, because you have a high risk of not having any more possibility to control the story of the patient. If the patient has low risk, then consider liver resection with a minimally invasive approach, video laparoscopy. This is therapeutic hierarchy, guys. And follow up. If a patient has an early recurrence prediction after resection, consider a preemptive liver transplant, as the paper by Fuchs and colleagues have suggested. And if you don't, salvage transplantation is the choice. It's not true that we don't have enough donor resources. In the last years, in Italy only, we had a 10% increase of transplantation every single year. So I have plenty of donation, and we have a decrease in the waiting list. We have partial livers. I don't go into the details of this, but you have machine perfusion, you have living donation, you have massive possibility to transplant these patients. But let's say that you are in a low resource scenario, you have very low donors, same situation. If you have an high benefit patient that the compensated cirrhosis, you should consider transplantation anyway. If you have a resectable patient, you must go for a liver resection and follow up the high risk for, very early recurrence, and consider an enhanced follow-up, even a 2 months CAT scan and a very high recall policy for this patient. And consider salvage liver transplantation. Salvage liver transplantation for the very young guys is a transplant that you consider in the second line. But please, watch out, salvage liver transplantation is associated to a 61% failure. Only less than 40% of the patient can be really salvaged. And those that recur and cannot be salvaged have a 7% survival at 10 years. So the famous salvage transplantation policy is a failure. You should not go for salvage. You should go for preemptive transplantation. This is the new approach. Otherwise, at least you have to advise your patient. Wait, we resect you, but your risk of, recurring, not having a transplantation is 60 to 70% of the cases. I hope this is clear to you. And the last scenario, and then please stop me. Probably I'm out of time already, but it's very important, I think. Out of conventional criteria for transplantation, all comers, 20 nodules in a patient that can receive therapy should be considered in a transplantation setting. If you have a general contraindication to liver transplant, then you consider resection or ablation or, systemic therapy, whatever. But if you have a general condition, potentially good for transplantation, a 60 years old guy in good condition, no frailty, no sarcopenia, you should consider downstaging in a transplantation setting. very expert transplantation setting. You have a failure, you don't do anything, unfortunately, but you have a partial response or complete response, then the benefit of transplantation is massive and should go. And this has been already, validated by a consensus that we did in Prague a couple of years ago and published in TI recently. So again, this is a very nice integrated policy. You should consider biology first, but then consider first the most relevant and better associated to results pieces of therapies, starting from transplantation, then minimally invasive resection, then ablation, including video laparoscopic ablation. I have plenty of slides after this, but I won't show. And then concluding with systemic therapy. What we are seeing now, that many patients, because there are many tools for systemic therapies, are subjected to systemic therapies, and they do not consider a conversion to higher hierarchical places that are associated with best survival. I stop here. I hope that I've been clear with this. I'm very firm on this because too many stakeholders are now taking care of hepatocellular carcinoma patients, and we need really to have order in our mind for the the benefit and the sick and the savage of our patients. Giuliano, to you.
Thank you, Umberto, for this really clear and important talk. If I may, I would suggest to use this checklist. The eyes should make pressure, and every hospital which deals with patients with HCC should have this checklist in the records, in the patient records, and then they should justify if they do something different than what is there. The problem is, of course, that there are not as many transplant centers as they are needed. If I understood right, you did 1,400 liver transplantation last year?
Oh, we did 1,600 last year.
Last year, 1,600 in Italy?
That's increasing like this. And in some centers, hepatocellular carcinoma is 60% of the cases. So we can do a rough number. 700 cases.
Twice as many as in Germany. So you really have so many patients. So what's the problem? We don't have hepatitis B anymore, of course. We don't have hepatitis C. I think it's Sangiovese or Chianti or let's say grappa for breakfast, or
eating too much, or eating too much.
It cannot be muffled. I don't believe it, And that's I think the change when you don't use alcohol, the word alcohol anymore. To me it's not good. Okay, but this is another topic. I agree with you, and I would suggest again, this eyes, which is doing really excellent work, should make pressure and use this checklist. Digitalization now it should make, and you get a patient presented with this checklist from Macerata, They send you the checklist and you say, okay, do this or do that, or send me the patient we transplanted. Thank you very much again. And other questions?
But just on the top of what you said, we are doing this in a prospective fashion. Every single patient is undergoing a checklist, exactly as you said, justifying why you're going down, and then reviewing this process, and you're analyzing which are the reasons why in expert centers, and giving you a fresh idea of what's happening, and that's really what should be done.
Thank you.
Now, if I just apologies, as I told the chat, I have to leave and leave you the lead, of course, of the second part of this webinar. And thank you very much to a pathologist.
Thank you. I think we still have only one talk, right?
No, there are two talks as far as I know.